Welcome! Today, we're going to build a clinical case file on a really interesting vesiculobullous disease. And the best part? The name itself, Linear Immunoglobulin A Bullous Disease, pretty much holds the key to its diagnosis.
Okay, so I know what you might be thinking. Another blistering disease to add to the list? It can feel like a lot. But trust me on this one has some really distinct features that make it stand out, which is awesome for your board exams and, for actual clinical practice. So here's our game plan. We'll start with what LAD actually is. Then we'll look at how it shows up in the clinic, how we lock in that diagnosis, how to tell it apart from other conditions that look just like it, and finally, how to manage it. All right, first things first. What is actually happening on a molecular level that's causing these painful blisters? Let's dive in. So, at its very core, Linear IgA disease, or LAD for short, is a chronic autoimmune condition. Basically, the body's own immune system is attacking the structure that holds our tissues together. This affects the skin and, super important for us in the dental world, the mucous membranes. So who's the bad guy here? Well, the immune system mistakenly goes after a protein called BP180. You can think of BP180 as part of the molecular Velcro that anchors the epithelium to the connective tissue underneath. So when it gets attacked, that connection gets weak, the layers pull apart, and you get blisters. Now, for most cases, we call them idiopathic, which is just a fancy way of saying we don't know what causes it, but it's not always a total mystery. We do know it can be triggered by certain medications, and the one that gets named most often is the antibiotic vancomycin. So this is a huge reminder. Taking a really thorough drug history is absolutely critical. Okay, this is a major point of confusion, so let's clear it up right now. When you hear IgA, your brain might immediately jump to celiac disease and dermatitis herpetiformis, but you have to slam the brakes on that thought. LAD is different. Unlike its cousin DH, linear IgA disease has absolutely no link to gluten sensitivity. This is a massive distinguishing feature, so definitely file that one away. So we've covered the why. Now let's talk about what this actually looks like when a patient walks into your office. What are the common things you're going to see? The presentation can really vary. On the skin, you could see anything from what looks like hives all the way to full-on blisters. But for us, the big takeaway is that oral lesions show up in the majority of patients. They'll usually look like painful ulcers or erosions because the blisters have already burst. Oh, and don't forget to ask about their eyes, because ocular involvement can happen too. Okay, so you see the clinical signs and your spidey senses are tingling. How do we go from just a hunch to a definitive, confirmed diagnosis? Well, this is where we need to look at the tissue itself. This is a classic two-step process. We need two separate biopsy samples. The first one is for a routine H&E stain, which just shows us the structure. The second one, and this is the important one, is for direct immunofluorescence, or DIF. That's what's going to show us the immune attack in action. So that first biopsy, the H&E, confirms what we see clinically. You'll see a clean split right at the basement membrane zone. And that little gap that's created is usually full of inflammatory cells, especially neutrophils. This tells us where the split is and that there's inflammation, but it doesn't tell us the specific cause. A few other diseases can look just like this. And this is the moment it all makes sense. The DIF test is the smoking gun. What it reveals is this sharp, continuous, straight line, a linear deposit of IgA right along that split in the basement membrane. And that, right there, is how the disease gets its name. It's what confirms the diagnosis, no question about it. All right, this next part is arguably one of the most important sections, both for your exams and for real-world practice. We have to separate LAD from all the other conditions that look just like it. So let's compare LAD to its main doppelgangers. Look at mucous membrane pemphigoid, or MMP. Both have common oral lesions, both have a linear DIF pattern. But here's the key. LAD shows IgA, while MMP shows IgG and C3. Then you've got dermatitis herpetiformis. Yeah, it also involves IgA, but the pattern is granular, kind of spotty, not linear. And of course, there's that solid link to gluten. Honestly, this slide is the perfect cheat sheet for telling these apart.
So you've done the work. You've confirmed your diagnosis of LAD. Now what? What's the management plan? And what can you tell the patient to expect?
Treatment is usually a step-by-step approach. We start with the first-line therapy, which is often a drug called dapsone.
If the disease is really severe or it's just not responding, we step it up to systemic corticosteroids, like prednisone, to get that inflammation under control. And for the most stubborn, tough cases, we might need to bring in even stronger immunosuppressive agents.
And that brings us to a final thought, something to chew on. We saw that a common drug like vancomycin can kick off this whole complex autoimmune disease. So it makes you wonder, right, how many other conditions that we just label as idiopathic might actually have some undiscovered external trigger? It's a huge takeaway for your future practice. A complete patient history can sometimes hold the key to a diagnosis that seems like a total mystery. For more deep dives like this, be sure to check out the Master Oral Path YouTube channel. Thanks for joining me.